and many of you I'm just getting a chance to know. Craniofacial morphology in the physical body is really my favorite track in this entire conference, and that's why I agreed to present in this track, and I've also been asked to chair this discussion. So much of the focus on somatic gnathic function starts and ends from the neck up, and what so many people really don't appreciate is the impact of the feet, the pelvis, the rib cage, all have on our ability to manage pressure and ground reaction forces that'll ultimately dictate how we breathe, chew, talk, sleep, swallow. And that ground is the ground under our feet. It's the ground that we're maybe sitting on, or it's the ground that we're lying on called our bed. And I've seen Ron Haruska look at a person's face and tell me exactly where they have a crossbite without looking in the mouth, and how this might have led to a bunion on their left toe. I've also seen him provide tactile input to a right arch of the foot, allowing for subtalar pronation, which in turn eliminated left orbital pain and restored diaphragmatic breathing. I've seen my friend Greg Johnson treat a foot to restore better mobility to a neck, to change the swallow. And I personally had Antonio Secco during my first fascial manipulation class clear a center of coordination fascial point on my hip that completely got rid of my knee pain that I'd had for several years. We know from the research and dissections of fascia that there's a continuous web, connections from our toes to our cranium, passing through every muscle and visceral organ in our body. When the entire body is not evaluated and treated, patients don't get better. When we treat symptoms instead of observing patterns of behavior, patients don't get better. And when we only treat one part of the body without respecting the entire system, patients don't get better. Lastly, when we don't communicate, collaborate, and celebrate the different lenses that we all have developed through our varied experiences, patients don't get better. So now I'd like to extend to each of you speakers, we have about 2 or 3 minutes each to discuss some of the difficulties that you see within your profession as it relates to craniofacial morphology in the physical body, and what are some solutions that you think we need to impart to start directing this problem immediately. And so, Samantha, if you want to help me call out some names here, because I'm on my phone.
Sure, yeah.
So if you wouldn't mind kind of
absolutely
passing the first.
Well, I would love to hear from Greg Johnson, who's joining us today. He is somebody who has been doing this. Well, you can explain how many decades, but your expertise and understanding of the physical body has been something that we have all learned from. And Greg, it's really a pleasure to have you here. We're so honored, and it's really wonderful that you out there get to hear from Greg. Go ahead.
Well, Samantha, thank you very much, and I appreciate that. Can you hear me?
Yeah.
Great. I happen to be here in Fremont, California, teaching a course. So the whole course is right next door to me, practice in the lab on intraoral mobilization right now, working on hard palate, expanding sinuses and other things. So it was a perfect lab to be doing at the time I get to share with you. I had hoped I'd be last because I would love to benefit from the ability to share what everybody else shares and expand on that process.
You can be last if you want, Greg. We can come back, but it's
that's okay.
Spotlight. Yeah, go ahead.
The human system, I think, is so fascinating that any one of us individuals cannot really understand the full nature of it. Unless your name's Ron Hershka, then that's possible that his knowledge has extensive amount of ability in so many areas. One of the things I found, this is my 50th year of being a physical therapist and in dealing with issues. And these last 5 years have been some of the most exciting when I've really been exploring airways, vagal nerve, autonomic nervous function. I started out really with fascia as being my whole interest in understanding the interconnectedness of the whole system. Now, as we really look at facial morphology and really starting to understand that so many of us did not go through a normal developmental sequence. Not only did we not do it physically, we didn't get adequate amount of time on the floor that most of us really needed to be able to develop our coordinated system and develop our system as a whole, but our face really didn't develop efficiently. The one thing I'd like to add is that through manual therapy, it's amazing how fast we can expand the hard palate. We can bring it forward. We can reinstate sphenoid function, open up the airways, and get someone functioning. And so the collaborated effort, as all of us are talking about, is the essential component here. Can we collaborate with individuals that can fit in those areas that we don't have abilities in? For those of us who are manual therapists, we believe that our hands can make huge difference. We can identify dysfunctions that are limiting airways, limiting chewing, limiting swallowing, limiting speech, limiting the vagus nerve function, and be able to make amazing differences in it. So I think that that's an introduction at this point. I've probably taken up my couple minutes already, and I'll relieve to someone else and maybe at the end be able to wrap up with some additional thoughts I haven't thought of at this point.
Thank you. It's, you know, you bring up so many fascinating elements of the physical body. And I just want to remind people that we have 136 presentations inside our Congress. And not everything is here right now. So if you're going into the Congress and looking and learning, all of these elements are really inside. And that's what our goal is, to share this knowledge from these experts. So, you know, please remember that part of it. I wonder if Cynthia Peterson would be available to speak. And also, I know you wanted to share some slides. You can get those ready. Cynthia Peterson is a physical therapist. We actually met her through the publication of her book, The TMJ Healing Plan. And from there, we've collaborated. And it's wonderful to have you here, Cynthia.
Great. Thank you so much. I hope, are you
You can
are
see
you
it.
able to-
Yep.
Okay. So I think pictures, I'm a visual person. And first of all, it's such an honor to be here with each of you. I love osteopaths, dentists, all of you, speech language. We all have, everyone has a role to play. And I honor each professional as well as each discipline. And there are some really important pieces that I think we as a group, as a craniofacial, getting the whole body picture, need to somehow get the word out there, because it's not, it's being missed. And if we just go in clockwise order. So if you see the gal, my patient up at the top, she came in, she had jaw pain. You can see the forked tongue. Well, most people would say she absolutely had to have a release. Well, within a week, so I worked on her whole body. I did maybe 20% in her mouth, gave her homework. She is a physical therapist, so she's very committed and knows her body. But she, within 1 week, her forked tongue was gone.
Wow.
So that's huge, and people don't get that. And I see a lot of clients who I think are already scheduled for a release, who were able to work things out. And some release providers are good about not doing that, but some are not. So the fascia and the whole body connections are really important. If you go to the next slide where you see the tongue partway lifting, this child had actually had a release, did their exercises for the 3 weeks, and totally scarred down. Now they had some autonomic nervous system issues. They had some hypoglossal issues that needed to be addressed, and whole body posture that had not been addressed. So the SOP actually sent them to me, and we were able to get them up to where they needed to be, but it would have been so much better if we'd addressed those issues before surgical release. And what people don't understand is that surgery, it's irreversible. They continue to remodel their scar tissue for up to a year. It's not just a 3-week thing. It's a long-term thing, and it changes everything. So we want to make sure, I love the motto, measure twice, cut once. If they need it, if we can, we want to avoid it. If they need it, we want them prepared, and we want them to have the very best results. The next slide is Arnold Schwarzenegger with a diastema space. And this is something I'd love the osteopaths. I've thrown this out to the stecho and the fascial experts, but I believe that the diastema, that space, is actually a connection, a fascial connection for the cranium. And I have seen some upper cervical instability when those have been released. And I think that's a really important piece. Everything that we've cut from the body, we've later found out, oh, tonsils are important. Oh, those wisdom teeth are important. And I think the diastema and even maybe the frenum have some function, and that we need to really investigate this more carefully. The gal in the upper right-hand part of Arnold Schwarzenegger, she had a diastema release as a child because they wanted to close the space, but they didn't close her mouth. Now she's having pelvic floor and incontinence issues. So we need to treat that whole body. And we'll see a lot, people I think are missing the pelvic floor connections with these patients with oral issues. The next client down, you can see the tilted bite versus the even bite. So this was in an hour, I was able to get him more aligned, but I'm seeing clients who are in permanent retainers who are locked in dysfunction. So I would like to get the message to the orthodontic community, hey, you need a whole body professional, an osteopath, a physical therapist, a manual, chiropractor, someone who can align the entire body and get that aligned before they do more permanent retention. Looking at the bottom next picture, breathing, everyone's focused on the box, the nose and the throat, which are so important, but really we need to look at the diaphragm, the pelvic floor, that intra-abdominal pressure, and all the way down to the feet. Hypermobility, you can see the thumb, this is from my book. This is the Baton Joint Mobility Index. Hypermobility, I believe, increases collapsibility of the airway. It definitely affects function. Sometimes that fascial tightness is a compensation to stabilize. So we need to start looking at hypermobility. Of course, scapular issues are important. And with the omohyoid, there's connections that I think are often overlooked. And then this is profound. So working with babies has been so instructive to me because you can't give them exercises. So this was a baby that I saw, he'd had a release, he couldn't nurse, and basically we had to turn on his cranial nerves. So we had to get things activated. And you can see by the end of the session, he was awake, his body was engaged, his cranial nerves were functioning. And we've been able to, through cranial nerve work and activation of the genia glossus and some of the others, improve things enough that he can nurse. But that is a huge, huge piece that people aren't looking at enough. Then if you see the top patient, the bottom left corner, you'll see this cute little guy who has a small retruded mandible. So they wanted to basically break his jaw and pull it forward. And the mom said, oh, I don't want to do that. What can I do? Are there any options? And we were able to release the suprahyoids. We had to work with the nervous system and his gag to be able to get his tongue up and calm his breathing and work through his reflexes. He'd missed a lot of steps. But through releasing that, you can see on the bottom picture, he's able to seal his lips. So no breaking of the jaw was necessary. And I love that they're doing early ortho, but we need to be doing, there's so many babies with small mandibles. And I find that by releasing those restrictions and encouraging those sutures and that growth, that we can actually epigenetically improve things. And of course, there's the dura.
Cynthia?
Yes.
Hey, we're actually, I love this presentation, but we've only allotted like 2 or 3 minutes per person, then we're going to have discussions. So I just want to make sure everybody gets an opportunity to chat here. But I have some questions for you toward the end for sure if we have some time. But great presentation.
And you can comment on Greg, and I loved your hyopharyngeal thing. So I think that's huge, hugely important. So I will stop sharing and thank you.
Thanks, Cynthia. So Ron, you want to pick up the baton here? Ron, you have to unmute yourself.
How about now? Can you hear me, Brad?
Yes,
Yep,
we can
I
hear
can
you.
hear you now.
Okay. Well, good morning, everybody. It's nice to be here. Thanks for the invite, and I can listen to each and every one of you, and I'm sure everything that everybody's going to say on this panel is we're all going to sit there, nod our head, and agree with. I really look at the body and the way the body works in a system way. It's an intralimb issue. We talk about tongue, and there's a lot of people in this audience that are going to be very interested in the oral pharynx and the oral pharyngeal region. Obviously, that's what this is all about. We forget that we have, some of us, I think, forget that we also the tongue owns a body, and the body can be tied down. And when the body becomes tied down, tongues will show and manifest different patterns, as will all of our 5 extremities, including the neck. And so, the opportunity to look at the human's ability to regulate tension and regulate it through looking at chest wall cavity, lateralized efforts of our 2 sides of our body, the up and the lower part of our body, is really kind of an important thing for me. We forget, I think, a lot of the disciplines out there are so tied into and so narrow-minded because of how we're taught. But I can tell you, every discipline offers something to this discussion, and I appreciate the discussions earlier by Greg and Cynthia that it is pelvis, it's pharyngeal, it's larynx, it's resonance of the chest wall. Our bodies are tied and tuned into what I would call respiratory malposition. Respiratory malposition is resonance. We have a hemisphere in our left side of our head, and we have a hemisphere in our right side of our head. And that directs hemispheric activity all through our body and how we react to what's being placed around us environmentally, how we see things, how we hear things, how we resonate our bodies to do that, and how we use our bodies to filter all this incoming information results in what I would call a pattern position. And when we use our tongue and our mandible and our hyoid to direct our body from the top down, we usually end up with a lot of autonomic issues, a lot of sleep issues, a lot of physiology issues, gut issues, vagal issues. We don't have a recurrent laryngeal nerve for, just because we have, a nerve that on one side of the body needs to go back up to the neck after it goes through and around some vessels of the thorax. We have it because our body needs to recurrently move from side to side. And when we forget that, and we forget about those influences on us, Brad, I think you see outcomes that are pretty predictable. So you can predict what the inside of the body is going to look like by looking at the environment that individual is exposed to and how they manage that environment by patterns of many systems, including the 5 extremities we own. So that's about all the time I have. And Brad, I appreciate your comments. I enjoy interdisciplinary, multidisciplinary mindedness. And I've learned more in my life as a physical therapist by working outside my career as a physical therapist with other disciplines that have showed me so much by looking at things in a different perspective. It's all about your perspective and how you use it. Thanks so much.
Wonderful. Thank you so much, all of you. It's been, it's really, we could listen to you for a long time. And I wanted to actually bring in Virginia Johnson at this time. She's an osteopath. She's worked for years related to tongue function. And Virginia, it's wonderful to have you. Thank you for being a part of our world here at the AAMS and collaborating with you. Virginia, go ahead.
Oh, thank you. Thank you so much, Samantha and Mark. You have done an amazing job with this conference. It's quite remarkable. But I am going to talk about oral posture, sleep, and chronic pain. And I'm going to go back to the understandings so many of you have already touched on, the total body unity concept. You know, I think we always need to look at the body the way nature looks at the body. The body never took an anatomy lesson. We are various textures of tissue in gravity. It's one entire unit. And keeping that in mind, typically I might see patients coming in with headaches, neck pain, upper back pain, lower back pain. And once I started asking them about their sleep posture, I realized that the etiology for a lot of this had to do with how they were sleeping. And of course, they're not sleeping on their back because they're not able to sleep on their back. They can't sleep on their back because they don't have enough airway. I think there's a misconception that side sleeping or stomach sleeping is normal. It's not. It's common. In our more recent times, we have soft mattresses. Ancient people slept on the ground. You know, they might pad it up with furs or feathers or, you know, something to make the surface soft. But for the most part, people did not sleep on their side or their stomach. So a number of years ago, I had a patient and I would treat her upper back. Oh, I'm a fairly young person, I would say in her late 30s. And the upper back pain, the neck pain, it would be better for a few days after treatment, but then it would return. And I soon came to realize that she was sleeping on her stomach. And when you consider the total body unity, what's happening is that she's putting a twist in her spine that goes all the way through to the sacrum, to the pelvis, creating sacral torsion. And the reason she's doing that is she found a way to strain her airway to keep it open at night. It eventually came out that she couldn't breathe through her nose. She'd had a lot of allergies and recurrent sinusitis. So I guess I'm starting to make that connection when patients come in with that upper back, neck, head pains. All patients now, I ask about sleep posture. And when patients tell me they sleep on their side, they say, yeah, I do that because I snore. Well, great. That tells me a whole lot right there. They are just going to continue to recreate their pain until they address the airway. So with that, I'm just very appreciative because of this Congress and the work that Mark and Samantha are doing, because it's really, in my opinion, opening up the ability to identify a lot of the causes of this chronic body pain.
Thank you so much, Virginia. It's, you know, it really is a collective of speakers. And Mark, I wanted you to step in now and introduce our next speaker.
Good afternoon, good evening. My name is Mark Muller. I'm the Executive Director of the AAMS. It's so exciting to see this track come to fruition and bringing together, you know, really people who are touching different facets of this. And I'm really excited to see this. And I'd like to propose to this panel that perhaps might be time for a white paper on this subject. So you can take it up on your own. But it's a real honor to introduce Rosaline Laloz-Paul. Rosaline, she is president of the Society of Research in Osteopathy, Perinatal and Pediatric. So for the newborn and for the pediatric population. So this is the French Research Society. She's author of an amazing textbook. Maybe I should pin myself. Let's see here.
We got you. You're pinned.
Okay. She's an author of an amazing textbook. You know, it's the cranium of the newborn. And I know of no other textbook like this. I have this textbook myself. I was really lucky Patrick Fellis got it for me from the editor, who we have here today, Rosalind. So Rosalind, if you like, I can translate for you. Est-ce que vous pourriez parler en français si
Ah,
vous voulez?
merci beaucoup.
Bien.
Merci beaucoup. Bonjour à tous. Est-ce qu'il y a quelque chose qui passe sur une slide pour la présentation ou rien du tout? Je parle simplement sur les questions.
Oui, si on le fait tout de suite, il n'y a pas beaucoup de temps, mais si c'est prêt, on peut le faire.
On peut le faire.
Ouais.
Bon, je la mets à l'écran, ou vous la mettez vous?
Non, vous-même.
OK.
Alors, je l'ai prête, mais
J'ai une idée. Peut-être
Oui.
on peut envoyer plus tard à moi. Et après, on peut partager avec
hein?
tous. OK? So
Vous l'avez.
she has some documentation she's going to share with the group, and we'll put it out there for the scientific community and all the Congress. Commencez. Donc, qu'est-ce que vous voulez dire?
La difficulté, c'était de pouvoir quantifier les déficits de croissance des enfants présentant notamment des déficits sur le premier arc, c'est-à-dire des déficits embryologiques, soit une microsomie hémifaciale, soit un syndrome de Treacher-Collins. Et il n'existe rien pour pouvoir quantifier ces déficits et surtout savoir si on peut récupérer en partie le déficit de croissance dû au syndrome. Donc,
so I can interrupt so our viewers know, she's explaining the challenge of the birth and what this does to the physical body and some of the challenges that brings with the physical body into the world. And so the idea is to go back into this newborn experience of birthing and look at how the structures from there can go on a trajectory of alignment.
And if I can add, she also referenced as an example, Treacher-Collins syndrome. And these kind of syndromes, these craniofacial syndromes, and even, the meeting of the sutures, which is so little looked at, except in certain advanced osteopathic manipulative therapy techniques in these kind of infancy periods. There's so much that can be done to help these children that works in coordination with myofunctional therapy principles. And so I know in some discussions, this is something that she would like to posit as something that could be looked at as including this kind of manipulative therapy, sometimes referred to body work, as a future dreamed of standard of care for infants in interaction and intervention, myofunctional therapy for infants, if you would. OK, commencez. Est-ce qu'il y a quelque chose d'autre?
La difficulté, c'est vraiment de les quantifier et de pouvoir les traiter très précocement. C'est-à-dire, si on peut, dès la première année, et les suivre à peu près au rythme de 3 à 5 consultations annuelles jusqu'à l'adolescence.
OK. Merci beaucoup. Merci beaucoup. Merci pour votre travail. She said, it's really so critical to have this intervention before in the first age of life. But even up until adolescence, there are certain key points that are milestones that could be points of intervention that can have a huge impact on the development of the entire skeletal structure.
And specifically, 3 to 5 annual sessions for that child is what she's recommending through up until and beyond adolescence.
Merci. And we look forward to releasing her presentation. So it's in the current process of being translated. Merci beaucoup. So to be part of next month's activities of the Congress. Happy.
Thank you so much. And I would like to introduce Yuang Chu here. He's with us from Singapore, and I am very curious what you would like to discuss, and please introduce yourself and your work.
Good evening over here, and of course, good morning all around the world to US. And my name is Yuang Chu. I'm a general dentist. I think my role here is rather interesting. I think as a dentist treating TMD issues, I have many opportunities to work with physical therapists, osteopaths, chiropractors. I really learn a lot from all of you. Because I think one of the big problem is the jaw as a joint from the body is taken out of context. So we are not putting this part as an important component of the whole body. So just allow me to share my screen quickly. And yes, so as I'm sharing this point that the TMJ actually is very important, right? And we need to identify this component as part of the whole body. And before we set our teeth in the right position through orthodontic, prosthodontics, and even just simple restorative work, we must observe that the TMJ and the AOJ are the articulating joints of the lower jaw and the upper jaw, right? And we measure, for me, I measure using this system, enabling me to identify where the patient really wants to be in terms of the lower jaw and the upper jaw, taking into cervical extension, right? And later on, lower jaw positioning in 6-axis before we proceed on with devising either spleens or eventually doing orthodontics that can finish the case and get the patient into a right position and treating her TMD overall. So this is the kind of work that I'm involved in, and I'm very happy and to be able to, like say, contribute to getting the patient into a right orientation, especially in the cervical area, before setting the teeth. That has an influence because teeth are skeletal units, right? And this is my like say work so far. And of course, as a dentist, I'm always looking into the mouth. The tongue is a very important component as well. So looking at the hard tissue, we need to also take into consideration the soft tissue, right? And combining both, right, we're able to bring our patient to in a better position, right? And looking at identifying the problem as airway, which already being discussed by many of our panelists, right? We know that the compensation with the forehead posture will bring forth many issues. And identifying soft tissue issues of the tongue, being able to train it through myofunctional therapy as a dentist together with myofunctional therapist, right? And then able to set the jaw position into a good 6-axis orientation, and then moving the teeth into the position that will support this hard tissue position, right? Then I sort of more or less complete this whole rehabilitation in this area. Of course, while doing this, I'm not doing it alone, right? Again, working with many colleagues to then continue to help the patient to equilibrate from head to toe, right? And from toe to head again. Yeah, that's my role.
Thank you. You know, everyone is really discussing many elements of this collaborative unit. And the next person I would love to introduce is Sylvia. Please introduce yourself. You're here from Germany, and we've enjoyed your participation in the AAMS Congress. I think you're a natural follow-up to this discussion. And just unmute yourself, and then you're ready
Yeah,
to go.
thank you very much for the introduction. My talk deals with the treatment of patients with infants with Robin sequence with the modified Tübingen palatal plate. This is a palatal plate which has a prolongation which shifts the tongue into an anterior position and thereby opens the airway in patients with obstructive sleep apnea, a very small mandible, and failure to thrive. This treatment was introduced in Tübingen, and we could show that it works very well. It introduces mandibular growth, and it releases upper airway obstructions. So the children have no more failure to thrive. But this is a multidisciplinary treatment. It's important that there are neonatologists which work together with orthodontists, and we need a sleep lab and an experienced nursing team. But what is extremely important is that we need a speech therapist which is familiar with orofacial regulation therapy, so that we can stimulate the tongue function and all the oral soft tissues, and thereby swallowing becomes possible and easy for the children. This is a very non-invasive treatment compared to other more invasive treatment options, such as tongue lip adhesion or tracheostomy. So all our patients with isolated Robin sequence could be treated for more than 10 years only with the Tübingen palatal plate, and we had no tracheostomy in patients with isolated Robin sequence when we used this treatment. I'm very glad that I had the opportunity to present this treatment in this conference, because we would love that more teams are able to use this treatment in order to offer it to more children all over the world. Thank you very much.
Thank you very much. And we're really excited. Your university, Tübingen, now has the largest pediatric sleep center in Germany and a very great team. And I'm sorry, with COVID times, I was invited to be a keynote there at the Pediatric Sleep Congress in March. And I look forward to going back there. And our institute has been invited to help set up a myofunctional therapy center for research with your team and several other teams, including the pediatric sleep team. So I look forward to following up on that with Miria Quante. Yes, so thank you.
We work together when I've been to Tübingen, yes.
I look forward to introducing next. We just have a little bit of time. So very briefly, Jedre Berchin Felix really is part of a team at University of Sao Paulo, Bauru, that has the only randomized controlled trial on orthognathic surgery and myofunctional therapy. It's a great surgical center for the world. And Jedre, would you please be brief? We just have a couple of minutes. Thank you.
Thank you, Mark. Hello, everybody. Thank you for introducing me. I am a speech therapist, and I've been working with dental patients for a long time, especially patients with skeletal malocclusion, and also patients with TMG dysfunctions. And I'd like to talk about two important points. Sometimes we have a patient and the problem related to the body posture is very, very related to the oral functions. It's hard to understand what comes before, what comes first. If it was the body posture or the altered body posture is a compensation of, or is because the out of functional problems. But in the TMG patients, we always can see problems in the neck, especially in the neck postures related to the chewing functions, and the pain is during the rest and is during the function also. And it's very, very important to organize everything. But sometimes we can have, I see patients, auto breathing patients, and the adaptations in the mouth and in the neck to provide a better airflow to breathing can change the body posture. Then it's impossible to get a better breathing condition if I don't modify the body posture, because all muscles are connected. And it's very, very important to think about our therapy. Then I was talking about the diagnosis, that we have a relationship between TMD disorders and body posture. We have a relationship between auto breathing and body posture. But if I would like to treat these patients with these kinds of disorders, I always need to understand the whole, and try to reorganize the body posture.
Thank
first.
you, Sandra. You're bringing up all of these very important functional elements, which is why we have physical therapists, osteopathic physicians here, dentists, orthodontists. This is not just physical therapists, but we are working as we do with treatments for the whole body. So before I want to pass it over to Dr. Stecco. Antonio Stecco's work in the fascial manipulation, but also understanding the human fascial system has been paramount. And we're very happy that you're able to come here today. And Dr. Stecco, we would love to hear from you. Great.
Well, thanks for the invitation. Really nice to be here. I would like to well, introduce myself. I'm a physiatrist. I'm a PMR. I'm working as assistant professor in New York University. I wanted just to explain a little bit more about fascia.
Okay, we're having a little bit of a connection issue.
About a new MRI that I would like to share the screen, but I'm not allowed to.
Oh, you can. Okay. Just one quick second.
I have like a 7 slide quickly.
Okay, we're running out of time. So maybe briefly, can you go straight to the ones that you feel are the most pertinent?
Okay, so to take in consideration that it's impossible to separate the fascia of the neck, the fascia from the mouth, the fascia from the chest. So you have to address different kind of fascia in order to restore the biomechanics. So the human body is really so
Dr. Stecco, I'm afraid we're having some connection issues.
With a clear knowledge. So in NYU, you're going better. Can you hear me better?
Yeah.
Just a little bit better. Yeah. So what I would like to explain that in NYU, we find out a new MRI we call T1 row that is able to evaluate the alteration of the fascia in the way that is able to codify how much fluidity there is in the loose connective tissue between layers. So we published the first article in January. In this way, we can now give like a new tool for clinician to make a clear diagnosis of myofascial disorder, and so to address a better treatment. So this is like a summary of what I can explain, but I will be happy to share my article in case they need.
Yeah, actually, we would love to have that, and we invite, please share it, and then we will distribute it to the group. And also, get everything and your presentation inside the Congress, but we will be reformatting this panel as well, so we can include those slides at another time as well. We have some connection issues with the sound with you, I'm afraid. So we weren't able to hear everything so perfectly. So we can come back to it for sure.
Okay, thank you.
In
Appreciate it.
post-production. Thank you. Mark, did you want to say something? Because I know that we
are coming up on the hard stop time, and really I encourage everyone to visit the people in this track. It's such a critical element, and tying together the posture, the workshop from Ron Hruska is just a gem of 4 hours. And Dr. Antonio Stecco just recorded a mini workshop for us. So that will be released and spotlighted next week. And, lo and behold, the tongue is tied to the rest of the body. And as my mother always said, the tongue is the rudder of the spine. So thank you so much for your work. I'd like to challenge you all to carry on this discussion. And I want to challenge you perhaps to consider a white paper. Thank you very much. I'll collectively reach out to the group and we'll carry on this conversation.
and
But
also
right now,
I just wanted to say one quick thing. We have someone here who was not able to present. I didn't see his name. This is Sergei Minaev, and he's from Russia. He's PhD DDS.
maybe let him say hello for 1
please-
minute or 2 minutes.
Please say hello. Go ahead, unmute yourself. Yeah. Unmute yourself, please. Unmute.
Do you hear me?
Yeah, now we can.
Yeah,
Go ahead.
Thank you very much. I'm very proud to be surrounded by such great scientists, doctors, and now I feel myself like I'm a member of big family, and this family is very friendly because we are on the same wave, on the same tune. So thank you very much, and hope to see you soon. And now I've got an impression, I've got a kind of power to continue my work, because now I'm a member of such a great team. So
Thank you so
very
much. It's wonderful to have your participation. We have 43 countries represented in our Congress. So it's really, we're highlighting a collection of experience. Brad, I wanted to have you maybe wrap it up here before we sign off.
Thanks, Samantha. Thank you, everybody, for sharing your vision, your thoughts. This is such a, really, we're on the cutting edge of this, and the rest of the world needs to know about all of our work and how we're working together to find solutions to be able to address these issues in infancy and early adolescence, prior to these issues becoming problems of adulthood. So continue with all of your great work, continue to share your work, and we look forward to hearing from all of you in the very near future. Thanks, Mark and Samantha, for all you do.
Thank you, everyone. We will follow up with you all, but I just want to say thank you again. And to our viewers, we're going to take a 10-minute break, and then we'll be back live with our next track. And we're going to go into track 7, which is sleep and myofunctional therapy, in just a few minutes. So at the hour, we will start the next panel. And these are presenters who are in our AAMS